but now has also shown us overall survival benefit with longer follow-up.
Let's talk about the patients who maybe did not achieve a pathologic complete response. Maybe let's start by laying some groundwork here, and could you talk a little bit about residual cancer burden and how you are using or maybe not using RCB to guide your practice?
Yeah, no, I think, residual cancer burden is very interesting. It can be a little tricky for all pathologists to actually spend some time. It is a little cumbersome for pathologists to do that. So do our institutions routinely do it, or do all institutions routinely do it? No, they necessarily don't. But we have been going with just residual disease that has been reported out post-surgery in the pathology reports and going by that. And that has been what has been utilized in trials as well for eligibility criteria. So currently, our current standard of practice is neoadjuvant-based approaches, just because we want to try and get that PCR level. If we don't get pathologic complete response and have residual disease, we have the Catherine data that showed us not only invasive disease-free survival benefit, but now has also shown us overall survival benefit with longer follow-up with utilizing TDM1 or radiotrastuzumab emtansine in the residual disease setting. And so, but now we also have data coming out from Destiny Breast 05, which is not surprising at all that TDXD was superior than TDM1. I mean, certainly we've seen that happen in the metastatic setting. We saw that with DB03 as well, where patients who got TDXD had a better benefit than TDM1, and that has replaced our second-line approach, or had replaced TDXD with the TDM1 in our second line. So using that same thing in DB05, I'm not surprised that we've been able to show superiority for TDXD. But I think when we think about DB05, who were those patients? I think Catherine obviously allowed a lot of patients that achieved a lot of benefit with that approach of TDM1 residual disease, but there were still those patients whose outcomes could be further optimized, because if they had residual nodal disease burden, they were somebody who would probably have a lower IDFS rate than somebody who did not have that residual nodal disease burden, or the larger tumors definitely did not achieve a similar degree of benefit in IDFS rates. And so it was very nice to look at Destiny 05, which focused on that highest risk patient population. So inoperable tumors, or if they were operable, they had to have residual nodal disease burden. And then those patients were then randomized to receiving TDXD versus TDM1 for an invasive disease-free survival benefit as a primary outcome. And lo and behold, it was very impressive. Hazard ratio was 0.5, showing superiority for TDXD over TDM1. Very impressive data. And also, disease-free survival was also something that we saw in the trial. And again, benefit seen for TDXD, not surprisingly, over TDM1. So I think very impactful data there as well. The trial did allow patients to have received any kind of neoadjuvant therapy. There were patients who got anthracyclines. There were patients who got non-anthracycline or TCHP-based regimens, and then get randomized and still show benefits. So really applicable for anybody with inoperable tumors or residual nodal disease, where we would want to offer these therapies and derive the benefit that they did.